Sounds good.
It's loading right now, so hopefully.
Perfect. All right. Well, Amy, I think you can kick off, and then if we can always add Natalie on after.
Okay. Too. Hold on 1 second. I'm just gonna pause YouTube. So there we go. Okay. Grab my notes. Well, welcome everyone. Thank you so much for joining our Fireside Chat. If those of you who don't know me, my name is Amy. I'm a senior program manager with the Borgen Project, and I help a lot with congressional meetings and meeting with Congress and scheduling those meetings for all of you, all of our volunteers who are constituents of the leaders that we meet with. So that's a little bit about me. I'll hand it over quickly to my co-host, Kim, who will introduce herself first.
Sure. Thanks, Amy, and welcome everyone to today's chat. My name is Kim, as Amy said, and I'm based in New Jersey. I'm the Vice President of Policy and Communications at the Borgen Project, and really looking forward to today's discussion on global health equity with Owen, and we might have one other guest speaker joining us as well.
Yes. So first, before we get started, I really quickly want to introduce Owen. We're really excited and really grateful to have him on the call today for everyone. I'll just quickly introduce Owen. So Owen is a senior program manager for global diagnostics at the Clinton Health Access Initiative. Owen currently oversees CHI's cervical cancer diagnostics work and our country and global level COVID-19 diagnostics work. And hopefully we have also Natalie Gill-Mensah on the call. She might be joining us too, and we can introduce her hopefully when she joins. So yeah, we can get right into it. Owen, I don't know if you wanted to give a little bit more information on yourself.
Sure. Yeah, I can start. And hi, thank you for the invitation, and hello, everybody. So as mentioned, I work on our COVID diagnostics work at CHI, and just to provide context of what that means and kind of how we are positioned with just globally is that we work in two phases. One is at the global level with partners such as WHO, FIND, Global Fund, even the US government in a lot of different capacities. And then at the country level with individual ministries of health, partners on the ground, and we really serve as a conduit of information between those two agencies. We serve as a technical advisor to countries, and also, providing a lot of insights and information up to global partners. There's a third kind of, if you want to think about a triangle, the third piece is being the suppliers, right? The entire market that's supplying and providing products to both to global entities and also to individual countries. And you can think about that across any sort of product, vaccines, testing infrastructure, testing kits, across the board. And so really we kind of sit in that interesting triangle, and really that's where we play. So hopefully that provides a bit of context on the work overall.
Yeah, thanks. And before we dive into talking more with Owen, since Clint is also a panelist on today's call, Clint, I'll have you introduce yourself as the president, founder of the organization. Yeah.
That's about all there is to it. Yes, I'm the president of the organization. Owen, really excited to have you on board and just get your insider feedback as someone who's on the ground working on these issues. It's really helpful for us as an organization that's working at the political advocacy level to get the more we can learn about what's going on the ground and what's working and not working, and it's super helpful. So we're really excited to have you on as a guest.
Yeah, and speaking of what's happening on the ground, you're in Rwanda right now. So maybe you could start, Owen, with just a little bit of an overview of what the experience is right now today with the pandemic.
Sure, yeah, definitely. Yeah, and so I think Rwanda is a really interesting and exciting country to look at in terms of the way that they've handled the pandemic to date. Back in March, April of last year, Rwanda was one of the first countries to institute a lockdown on the continent here. And as and that lockdown obviously was grounding of flights, but also stay-at-home orders, and it was enforced in a pretty dramatic way. I think you can think of back in the U.S. the way the stay-at-home orders are enforced. Depends on the governor, depends on the state. Here, if you are found outside of your home, outside of curfew or during the lockdown at any point, without a pass that's approved by the police, you're actually taken to the national stadium or the local stadium in your district or sporting center, and you stay there overnight. There's public health messages that are played over the speaker system. So just, I think in terms of implementation and mitigation measures, very, very stringent. As the pandemic progressed, the country was able to, because of those measures, open up much earlier than I think a lot of other countries, both on the continent and globally. We see now testing here is at a much higher rate than pretty much any other low or middle income country per capita. And so we see positivity rates, which I think a lot of people know is a pretty strong indicator of testing. They've remained under 1%, which is also, I think, quite dramatic. And so just here in the country, there's been a lot of progress. And most recently and most exciting, there have been distribution of vaccine supply, both so through two different entities. One is through the Global COVAX organization or entity that is coordinated by WHO, and then also through direct procurement from suppliers. And so at this point, and over the course of 2 weeks, all healthcare workers in the country were vaccinated with the first dose. They've now all received the second dose, as well as elderly populations and a few other tiers. So if you think about how vaccines have been rolled out in the US through different priority groups, the country here has followed a very similar pathway. And, unfortunately, at the moment, we're out of vaccines, so we're waiting on the next supply. But there's been a lot of work and a lot of progress so far to get both testing and vaccination scaled up dramatically.
That's great news that vaccines are being rolled out. And do you have any kind of sense of how much longer you'll have to wait for the next supply to come in, or not yet?
It always depends. We have bi-weekly meetings with, so here it's called RBC, the Rwanda Biomedical Center, that kind of coordinates all interventions, both from the diagnostic side to the vaccine supply side. It changes each week as we hear about who's accepting AstraZeneca, who's not, and where different products are going. But we're hoping in the next month is the expected time point. So, yeah.
Great.
Yeah.
Go ahead,
Oh, Kim, did you want to go?
You can go.
Okay, yeah. So Owen, one of our volunteers, Naima, she's from Atlanta, Georgia. She had asked about reluctancy to receiving the COVID vaccine, but can you speak in general about, misinformation and how that's tackled where you are and within your work?
Sure. Yeah, I know this has been a pretty interesting and tough issue globally, right? So it's not just here, and it's not just in the US, pretty much wherever you are. So far, I can speak to Rwanda, and then I can expand it out. At least for key populations, particularly healthcare workers, here there's a lot of faith in the RBC, the government entity that is instituting the vaccinations. And so there wasn't a lot of hesitancy in terms of receiving the vaccinations through the first couple priority groups. As you start cascading down to more general population, and especially rural population, right? A lot of vaccination campaigns that are happening in low middle income countries really target urban centers first, and then expand out to rural populations, particularly because of the difficulty. The Pfizer vaccine, for example, is only administered in Kigali here in the capital city because of the requirements for minus 80-degree freezers, which are in very short supply in a lot of countries. And so there's certain areas where you can target to get really accelerated uptake, but once you start expanding out, it gets to be a lot more difficult. And so there's a lot of communication campaigns, and it depends on the country. I know Nigeria, Rwanda, Kenya, basically anywhere you go, and I'm talking anywhere you go, there are placards and signs about COVID and about washing your hands and about being aware of this as a disease that and how it's transmitted and your mitigation measures. So I think that amount of information, the fact that it's ubiquitous, helps people get more comfortable, start to remove some of the stigma. But I'm sure a lot of you are aware of the stigma around pretty much any disease, and that's continuing with COVID. So those campaigns are definitely expanding. And one key strategy that is going to start being utilized, which was a big one for HIV here, is using people that are essentially had been exposed already. They are survivors, if you will, and using them to get the message out. And especially across Africa, there's a whole population of community health workers, which are health workers that do not work in a facility, but actually go out and work in the community. They know the patients. They work in very small groups, and so they know each individual person. And a lot of the information campaigns are going basically mouth to mouth through those channels instead of just mass media, radio broadcasts or what have you. So these are different interventions, but again, it's going to be difficult. We probably are not seeing it yet here because we haven't hit the vaccination coverage levels that have been hit in the UK or the US, but we will be seeing it once we start getting around probably 50, 60%.
Sure. Great. I think Natalie is, I'm not sure if Natalie wanted to hop on now. Okay, great. Amy, do you want to introduce?
Sure, yeah, now that Natalie has joined us, thank you so much, Natalie, for joining the call today. Really quickly, I'll introduce Natalie. She's currently the Director of Programming and Training for Peace Corps in Ethiopia, where she manages a team of program managers and training professionals and provides oversight for a volunteer population of 100 to 150 volunteers. Natalie has also led global teams in executing complex multi-year programs in 12 countries in Sub-Saharan Africa and Southeast Asia. And she also serves on the Borgen Project's board of directors. So really happy to have her. And we know she is also a global health expert on particularly tuberculosis. And I know we wanted to touch on that and how COVID-19 has affected and impacted tuberculosis testing and that sort of thing. So yeah, thanks, Natalie, for being here.
Thanks for having me. My apologies for my tardiness. It's dinner time here in Ethiopia, and I was just finishing feeding my toddler. But I'm here live and direct and happy that you're already in the midst of the conversation. It sounds like it's going great. So
yeah.
Pleasure to see you all.
Yeah.
Great. Well, maybe on that note too, I think maybe we could switch gears a little bit to talk about the impact on other infectious diseases that you both have been seeing on the ground as it relates to TB and any other diseases that you might be focused on as well. What is the current trajectory looking like in terms of being able to tackle both COVID alongside other diseases, especially, like a lot of the messaging and, airtime is around the pandemic, but what are the impacts on TB and other diseases right now? And either of you or both can take that one.
I can start, and then Natalie, I think if you want to fill in, I'm going to make a couple different points. I think I'll start with the TB side because I think it's what a lot of people are interested in. Just across the board, so Global Fund, for those that are not aware, Global Fund is a global agency that pulls in money from a lot of different sources to be able to fund, in some cases, often the majority of a country's infectious disease portfolio. And so that can be, there's three main diseases that they've been supporting so far: TB, HIV, and malaria. And most recently, obviously expanding some money into COVID testing. But they did a survey just last year looking at the TB referrals from 2020 compared to 2019, and saw that overall TB referrals have dropped by 60%, 59% since 2019. And we know that TB itself is not disappearing. And so a lot of that has to do with hesitancy to actually go to health facilities and receive that care, and as well as lockdowns and being able to have access to care. So I think that's a first piece to highlight. What that also connects to, what I think is maybe a positive and a silver lining, is that Global Fund has also received a significant increase in overall funding envelopes. So last year there was what was called the C19RM. So it's the COVID-19 response mechanism. And this was money that was put aside predominantly to support and maintain existing HIV, TB, and malaria programs, but also a significant amount of money for countries to enforce, to input, to scale up their COVID response. So 900 million last year. Now this year, and I think hopefully exciting for a lot of the people on the call, the US government finally came back with money into Global Fund, which had previously been missing in 2020, and committed $3.5 billion. And that was increased by over 500 million from Germany and a few other sources. So now there's a bucket of over $4 billion that are going towards, again, those three key diseases and improving and maintaining existing programs, but also a significant increase in COVID-19 funding for test kits, for PPE, for just across the board. And so I think we're excited to see that influx of money. And any country you will talk about or talk to right now is in the midst of submitting their proposals on how they will utilize the allocation money that's coming to them. So I just want to flag that as hopefully a positive that we're seeing.
Yeah, thanks, Owen. Not a lot to add to that. I think you hit a lot of it on the buzzer. One thing I'll add in terms of the numbers decrease, part of it is, the fear of seeking care. And part of it is a lot of the health care facilities in developing countries have been transformed from TB supporting facilities to COVID because the COVID demand is so high. And so the TB, patients less can be seen per day. And it's kind of the same area of your body that's impacted with TB and COVID. And so a lot of the doctors who are treating, we're treating TB patients are now focusing on trying to control the pandemic. So that has been a challenge. But on the other end, I think some of the mask wearing, the increase in mask wearing, the increase in social distancing has benefited TB as well, because you kind of catch TB a similar way that you do COVID. And so with the increased mitigations for prevention of COVID, you in turn prevent some of the TB cases as well. In terms of access to treatment and care, particularly around vaccines, it's great to hear those numbers. Owen, you're in the midst of it, and to hear that there's money. As you're seeing with India right now, their primary producer, maybe you already said this and cut me off and you already mentioned before I jumped on, but India is a primary producer of the vaccines going through the COVAX channel to these countries. And now that they're overridden with COVID, they're kind of pulling back a lot of those vaccines that were intended for to supply African countries. And so that might have a huge impact, at least delaying our ability to reach and cover all of those folks. So I think that's something of note as well. Thanks.
That's really helpful, Natalie. And that actually answers a question we had in the Q&A box. So thank you for tackling that one too. Perfect. So I think maybe just in kind of wrapping things up as well, we could maybe just get some comments from you both just in general in regards to global health equity and how the effects on just, poverty in general, as far as the secondary effects, really, if you will, or the aftershocks of the pandemic, as far as, from an economic standpoint and all of those things, and how, if you have any insight on how that is affecting people who are already struggling to survive and what's kind of the way forward there? So two-part question, but any comments on that would be great too. Who wants to go first? Owen, you're first again.
No, I was gonna say, Natalie, if you want to kick it off. Otherwise,
okay, sure.
Yeah,
I
go
can.
for it.
I'm always going to defer to you, Owen, as our special guest here, to go first. So, in my perspective, living in Ethiopia, I'm currently in Addis Ababa, Ethiopia, and before the donation of ventilators from the U.S. government, there were very, very few ventilators in country, and so a lot of people didn't have care. Now the issues are that the more people are getting tested. There was it's been I don't know if you talked about testing numbers, Owen, earlier, but in the beginning, when it was like the bright shiny news in March 2020, through I don't know when the cut of testing date ended, there was a lot more testing. And then it kind of died away for some reason. Maybe it was availability of tests, maybe it was, moving on to other things. But the virus was still ravaging and increasing in number. And the reason we knew that was because, the epi data was telling us, even though the numbers were steady or going down, the percentage of those who tested were increasing steadily. So even just because when you test less people, you have less cases, but that doesn't mean you have less disease in country. So we know that the numbers are going up. Now I think, maybe it's a new administration that is really kind of sounding the alarm again on the importance of mitigating COVID globally. The testing has seemingly increased, and they're finding the numbers are really startling. I think Ethiopia is one of the top maybe 3 now in Africa. I know 1 or 2 weeks ago, we were the number 1 in new cases in the last 24 hours, like above South Africa, above Kenya, who already shut down. And I happened to be traveling with my family to Kenya, Nairobi, when it shut down. Luckily, we accessed vaccination through the U.S. Embassy, but it was still a risk travel, but we needed to get out. They shut down the country on the Saturday before we left. We were leaving on Sunday, and they had a curfew at 8 p.m. They closed all restaurants to delivery only. It was just basically shut down. And Kenya is doing better than Ethiopia, but we are still wide open. And we are still, there's a little bit more mask wearing, but a lot of it is happening in the capital city. So another challenge of the country is, the testing and the mitigation is concentrated in the capital, but outside of the capital where the infections are still growing, it's still a challenge. In terms of impact to business, I think people are struggling. Ethiopia is one of the most poor nations in the world. It's the second most populous country on the continent, and so there's a lot of joblessness because there's not enough jobs to supply all of the population. And the education system is pretty good, but not a lot of focus on English language. So there's limited things that people can do outside of kind of local market. So the economy is struggling, and they're trying to keep it open, which I think is a detriment to the COVID movement in the country. One more thing I'll add specifically about Ethiopia is, tradition and culture is really strong here. So we saw a big spike around the last holiday, which I can't remember what it was, but in holidays, everybody gets together, they're eating injera, they're sharing, they're opening their mouths all within less than 6 feet, right? And they're around family who obviously nobody's family can get COVID in the eyes of many people, right? And so they're getting COVID. Then they're going to funerals, which are heavily crowded events as well, because the culture is much more strong than the urge to mitigate and do these things. So that's one of the challenges we're facing as well here. But hopefully things will look up and we'll shut down soon, and we'll control. Over.
Yep. If I can add a couple of things, because I very much agree with what you're saying, and it really depends. And I think you pointed out one important thing about urban centers versus when you go out into villages or even just not the capital city, you see an entire shift in how people are responding to the epidemic, and the mask wearing definitely dramatically decreases. I will say Rwanda, everyone still wears a mask, but you see a lot more down around the chin as you go out into the villages. The point I want to make on the health equity side of things is, or just overall, is that there's a much larger informal economy that exists in countries in the region. And so a lockdown in the US where you now, let's say 50%, 40% of people can work remotely, you have different systems put in place for essential workers, that does not exist here. A lockdown in countries in this region, when you have 70-80% of people working in the informal economy, and by that I mean selling at markets, driving taxis or motos, and a lot of things, you first off have much higher exposure rates because everyone is interacting, but secondly, you by instituting a lockdown, you lose access to any sort of income in those regards. And so one thing that's been a hopeful sign, and I guess as you're saying with the increase in testing in Ethiopia, but also across the board, there's new tests that are coming available. There are these rapid diagnostic tests that are much cheaper. They're about 25% of the price of existing PCR tests, which is when you go to the lab and they collect a sample and they send it out, you wait and hope that you're negative. Those, first off, they're cheaper, but they also allow a country to dramatically decentralize testing. And what that does is that, let's take Malawi, for example. Malawi previously was testing in Blantyre and in the Lilongwe, in the capital. Now, all 26 districts are accessing testing in a daily rate, right? And so you can start seeing any district or even sub-district that you start seeing spikes in cases. So instead of Malawi saying we've increased cases by 100% the last 2 days, the whole country needs to lock down. Instead, they can say there's been 2 districts that have spikes in cases. We lock down those districts, but we allow the economies and people to continue working and existing in the public space in all of the other 24 districts. So my hope is that this type of strategy and policy will expand. The gap for that is again, having access to those tests, but also data visibility is still difficult. You go to a health facility in the region and everything is still written down at most facilities on a register, a paper register. And oftentimes, if I want to understand what's happening at a health facility, I'll have to text someone. I'll send a WhatsApp to a WhatsApp group, and 20 different health facilities will respond back and said, we tested 10 people yesterday. Great, but that's not sustainable at a national level. And so instituting a real-time data system where you have visibility is an exciting thing. Some countries are doing it, and we hope that more will add on.
Yeah, thanks. That's great information for sure. I wanted to go back to another volunteer question from Ulea from North Carolina. And this question goes to both Owen and Natalie. I'll just read what they have here. Experiencing and learning from COVID-19 as the world has this past year. As global health experts, what implications have you taken or changed to be better prepared in the future should a similar experience arise? How are you creating awareness of global health crises in general? Are you partnering with other global health organizations or governments? That was their questions for both of you. Yeah.
I
Go ahead, Owen. I think Natalie's typing the response to someone else.
I was typing. Go ahead, Owen, because you're the test master.
Yeah, so look, I'll talk about a couple things, and then I would love for you to chime in on some of the other areas. But I mean, I think this is a great question, and it's very difficult. Last year was incredibly hard for everybody, but in the global health space, the beginning of last year in March or in April, I think everyone heard about supply shortages, and and access to PPE, access to test kits, access to swabs. All of a sudden, half the world knew the name of this very niche swab supplier based out of northern Italy, but everybody knew who they were and knew that they were not able to provide enough supply. So what I think in terms of thinking, so what happened then? Maybe I'll walk through a couple things that happened and how that'll lead to preparation. At that time, one very, very key thing was the creation of a bunch of consortia. And consortia are essentially just different public health groups. I mean, you can have a consortia in any industry, but in this case, public health organizations coming together to set certain priorities and achieve those priorities in very specific ways. So in this case, WHO called the Global Diagnostics Consortium together, and there's also a vaccines consortium, that's COVAX. And the goal was to essentially identify supply of every key reagent, every key product that was needed, negotiate supply with those suppliers, and set up procurement channels, because there were no shipping. There was no way basically to get products. I didn't know this until then, but the majority of commercial shipping actually is on, at least air freight is on commercial airliners. And so you'll have when you have passenger flights that are grounded, there goes the majority of your procurement and logistics channels. So last year, the consortium was set up, and basically responsibilities were split amongst different entities to negotiate supply. And then WHO took on the role of creating an allocation mechanism. And this was incredibly important because countries like South Africa or India or other large entities couldn't buy up all the global supply of a certain product. Instead, suppliers committed to giving product to WHO, and WHO would allocate based on a certain set of metrics. How is a country doing? Do they have access to other supplies? And what is their healthcare infrastructure? So that there was a way of creating some degree of equity, global equity. It was exciting. It was tough. One issue is that one of those suppliers, their name is Cepheid, they're a global health supplier, they did not meet a lot of their supply commitments. And just last month, I believe I think over 100 CSOs came together and wrote an open letter to Cepheid about the fact that they were not playing well in the market. They're a US-based company. Over 80% of their supply has gone to the US and the EU, even though I think we all know what the population distributions are outside of those high-income countries. So thinking about what that means going forward is that those types of systems, those types of supply commitments, consortia being put together are going to be incredibly useful. We already have now infrastructure set up to bring those types of partners together. There's agreements that have been set up with suppliers so that supply is easily accessible. And finally, the other big issue with the supply accessibility is that there were, again, for swabs, one key supplier. There's another in the US, but they were not sending anything out of the US. The US government did not allow any swabs to leave our borders. And so it was this Italian supplier. And so many organizations, and us included, we went to virtually China, India, and reviewed all of the products that were coming out of these countries: masks, swabs, new test reagents. And the WHO put together very quickly a regulatory kind of process to dramatically review and increase the amount of supply and suppliers coming into the market, high quality, but with expedited review. So that process is now in place. So in 3, 5, 10 years, if we come across this again, there is a very quick approval process to get new suppliers in the market. And there's consortium that are set up to hopefully handle any supply constraints and issues and get things distributed out. And then the last is just, in-country infrastructure. There has been so much money and time and effort put into improving countries' testing infrastructure. There are countries that had, the beginning of last year, you probably heard, Burundi has not conducted, or Burundi has no cases. And the Burundi president came out and said, yes, we have no cases because we have no testing infrastructure. So we haven't tested a single human being. Now Burundi has procured a whole lot of PCR instruments. I know there's people flying there just next week to help train additional lab techs to be ready. So our hope is that the supply side is hopefully getting sorted out, and also from the country's capacity to conduct testing and handle the epidemic, a lot of systems have been put in place. Again, I'm talking from testing, but you can take that and apply it to any other area. There's been hospitals that have been built that did not previously exist. There's been additional people trained that were not trained previously across the board. So hopefully we're in a better place now, but complacency is kind of the biggest predator of that issue. And come 10, 15, 30 years down the road, we hope we're not, sitting back and we're trying to be more proactive in addressing those issues.
Absolutely, Owen. Yeah, all really great comments. And some of the things I think you were hinting at, which I'll say out loud as well, is, one of the reasons why I think CHI exists is to kind of support and advocate for countries that do not have access to some of these medicines, vaccines, and products. The challenge with the pharmaceutical industry is it is a for-profit industry that is looking to, make a profit. And so with that, similarly with tuberculosis medicine and the lack of innovation in TB, because it's a poor country disease, quote unquote, in developing countries. Similarly with COVID vaccine, I think, it might be partly concentrated in developed countries because they can afford to pay more for it, potentially. Correct me if I'm wrong, Owen, because I'm not as close to it as you are. And it has become a political tool on both sides of the aisle. So I'm not apolitical, we're a nonprofit organization, but it has become quite political. So a country's leader is judged and receives votes based on their ability to manage the disease. And so with that, they're going to, if they have the power to control more, supplies and prioritize their country, then that's what they're going to do. I mean, that's what some would argue they're supposed to do as, representative of that country. With that, and your question for intellectual property, I don't know if opening it up, potentially opening it up could be helpful to countries like Ethiopia and Rwanda. I don't know of any facilities on the African continent that can produce vaccines, but I know that, if you open it up, it would be tons more coming out of India, China, that would create more supply in the market. And hopefully it would be, is just as quality assured as we hope that our Pfizers and other things are, right? But yeah, that is my answer or non-answer to that question. I think there's a lot of different layers at play. I think this is one of the most politicized diseases I've ever seen. And I think it strongly impacts how the world receives or doesn't receive access to care and treatment. Or I shouldn't say treatment, but vaccine is a treatment. So yes, care and treatment.
Yeah, and I think Natalie too, I think the question on the IP waiver by Shelley is more specific to India and also South Africa, where the two countries that would be able to mass produce if we were able to share the recipe for vaccines. But yeah, Amy, were there any more questions that came in? I know we're kind of going close to the time here, but
yeah.
Or Clint, did you have?
I've got one closing question for both. So as an organization is focused on, what's wrong with the world, we're sometimes are definitely guilty of not focusing on what's right with the world too. So you both are in very unique, wonderful countries. And if you just want to, in the closing, give a couple minutes on why you love Rwanda, Ethiopia, where you're currently at, and why people should visit after COVID ends and come check out what beautiful countries you're in.
I think, go ahead.
I guess I'll go again. I mean, Rwanda's great. It's this beautiful, mountainous, everywhere you go. I mean, I wish I could show you, but it's nighttime now. Any angle you have here, you are looking across a valley and you see the peaks across the side. We're in the mountains. The whole country is built into the mountains. And, and I think because of that, anywhere you go, there's just these beautiful landscapes. There's safari on one side, a beautiful park where you can go around and actually self-drive, which is really exciting. You can just drive around amongst giraffes and zebra, and in the other direction you can go, and there's gorillas that are basically living on the side of volcanoes. It's a very diverse and interesting place. And I think what is also really exciting here is just the community, the people, everybody. You just walk around, you bump into people on the road. I mean, there's people now that I know just in my community, because again, everybody's just outside all the time. And it's also always 70 degrees, which is helpful. But yeah, it's just people are incredibly kind, incredibly nice. I see somebody mentioned Indabo. I was at Indabo all weekend, actually, playing board games. It's a great place. So yeah, it's really great. And I think one thing to flag right now, and I mentioned at the beginning, is just the way the country has faced a lot of issues is incredibly, I don't know if you want to call it technocratic or data-driven, but there's so many interventions here that start with looking at evidence. And you don't see that, and this even comes back to a bit, Natalie, what you were saying before about just the way that countries kind of look at trying to secure votes and et cetera. But here it's just, I go into the Ministry of Health and I present them with evidence that a new type of test might work, and they wholeheartedly, open arms, say, yes, let's try that out. And you see that in the way that the country has really grown over the last 15, 20 years, and how much has changed. And obviously there's a very complicated and difficult past here, and you speak to people and people are still so open, still so excited about the future. And I think that's an important thing to have, and is missing in a lot of countries, a lot of societies, that optimism.
Great, yeah.
You want to say something, Clint?
No, that's
okay.
Perfect. Yeah. I'm booking my flight now. I'll be right over.
Yeah. Oh, and I love Rwanda. I had a chance to visit when I was with Chai for a very brief moment, but there's like a going joke around there. People call each other and say, "How's your view?" Because everywhere you look, the view is completely gorgeous. So yeah, that's exciting. Rwanda's great. Ethiopia is, what can I say about Ethiopia? It's a beautiful country, super full of many, many people from different walks of life, different cultures, different experiences. It's about half, 40% Orthodox Christian and maybe 30 or 40% Muslim. And a lot of the celebrations and excitement happens around religion. Both religions have really beautiful festivals, and I have 13 extra holidays here in addition to US holidays because every religious festival there is a great celebration. Ethiopia is a land of history. It's a land of the Bible. You can find Bethlehem, Nazareth, the different, places you read about in the Bible. It's the oldest place of Christianity. And so if you're interested in that side of the world, not everybody's Christian, but it's an exciting place to explore in that way. And even beyond that, the historical strength of just having these spaces like Lalibela, Aksum, where things were built tons and tons of years ago. It's really exciting. And it's two-part. Like you go to the north of the country and you have all of that deep history I was talking about. You go to the south of the country, you can still experience a safari, see some hippos, and maybe not too many giraffes, but I think occasional elephant here and there. It's closer to kind of the Kenya side of the world. So you see kind of the experience change. It's warmer down there. We also are 70 degrees year round because we're on the mountains as well. So that's really nice. Even as we're approaching rainy season, we're surviving. I really love that your people are kind and generous and really proud. It's the only African country that was never colonized. And people like to remind you of that. And people are really proud of that, and as they should be. So yeah, it's an exciting place. Definitely come and visit us here.
Great. Well, thank you both. This is great info and really helpful.
Yeah, and with that, I think we can probably wrap up. But again, really appreciate both of your time and everyone for joining us as well as attendees for today's chat. And we look forward to seeing you all again really soon. And certainly if there are questions we didn't get to, just please email them over to policy@borgenproject.org and we'll be happy to take them there.
Thanks, everyone.
Thank you.